All right. I'm going to move pretty quickly today. I do indeed have way too many slides. I'm breaking all the rules for presentations here. If you're going to take pictures, do so really quickly because I'm going to move fast. There's a lot of new terminology that comes about as you deal with large employers that are interested in DPC. And these things get thrown around and nobody really has a clue what they mean. So this title is going to come back and hopefully you're going to see the point of it at the end of the talk. But there are these four large categories: HRAs, MEWAs, AHPs, and STLDIs that we're going to go through today. And the STLDIs and MEWAs you have to be wary of because there was a lot of historic abuse there, and now there are attempts to expand them, and there's been litigation around the new HRA piece. So here's your glossary. You might want to take a picture of that if you're into taking pictures, because I'm going to use a lot of these acronyms, and I can't help myself. Okay, so here's the actual timeline of what's happened, and I'm going to come back and play off this a little bit later as well. The broad piece that you might have already heard about is that on the HRA side, they've already passed new regulations which were invalidated just a couple weeks ago, and the Trump administration is going to appeal it and they're going to lose again. So don't rely on that too much right now. So bird's eye view, how did this all start? It started with ERISA, the Employee Retirement Income Security Act, and it covers any employee welfare benefit plan. So for the DPC ducks in the room, the first question is, well, does that matter? Does this apply to me? The answer is usually yes. If the employer is paying the bill, this is going to wind up under ERISA, and it really doesn't do much to you as a physician except add this 36-month rule that you got to be aware of with COBRA, which means if the patient gets fired from the employer, then you still got to have a way to see them for up to 3 years, and they can pay the bill themselves. Does this interfere with other tax definitions? No. It doesn't change the 223C or 213D provisions that are commonly referenced. That part we're going to skip through. This is for your reference later. Hint's going to make these available, and you can email me and I can send them to you too. I like this Heath Ledger quote from when he was playing the Joker when he says, "It's all part of the plan." That's kind of how you find yourself dealing with all this broker terminology that you don't understand. So ERISA plans, health plans, the IRS would call various plans health plans, insurance plans. These are all defined by different people at different levels, and they are not equivalent. Okay? ERISA is defined by the Department of Labor. Your health plan is defined by the IRS, and your insurance plans are defined by the state. And they all might think they have jurisdiction over each other, and they don't. So don't let them confuse you. So is a direct primary care plan a state insurance plan? Is it a federal health plan? Is it an ERISA plan? Well, the ERISA one, I already kind of spilled the beans there. Usually the answer is yes. Is it state insurance? No. Jay Keese just told you 25 states explicitly it is not insurance unless you do something really stupid and go well beyond the bounds of what they said is DPC. At the federal level, we're making that argument under 223C that DPC is not a health plan. The IRS thinks it is, and that's the biggest problem. The 213D medical expense is the secondary issue, which comes into play with HRAs a little bit later. So why would an employer prefer an ERISA plan in general? There are several reasons. They cost less than a standard ACA plan. You can now offer something nationwide because this is a federal law, not a state law, and they're familiar with them. They've been around since 1974, so what is that, 45 years or so. Legally, they've been litigated. It's not like this new stuff that came out with the executive order that's immediately been repealed the day after it was written. So employers know what to expect, and they don't feel like they're jumping into something new. So all these things might want to be an ERISA plan. Most of them can, and most of them take advantage of that from time to time. The STLDIs are a big no, so that's the one that you should sort of highlight there. And this will be available in a 2-page handout too. It sort of summarizes these things. I'm going to come back to it a few more times, but the other thing that happens when you're under ERISA is it triggers a fiduciary duty rule. So if somebody's pitching a product to you, if it's a MEWA or an AHP, and they say, we're going to be real creative with this, we're not even going under ERISA, it's only going to be sold in this one state, we only care about the MEWA laws in Alabama or wherever you are, then one of the bells that should go off in your head is, well, this is where things used to be abused. I wonder what Alabama's laws look like, and is there any fiduciary duty here at all, since this is not an ERISA plan? So the executive order came out and wanted to expand all these things that I first mentioned at the beginning of the presentation, and that's sort of a summary there. I'm going to blow right through this stuff. And we're going to get to the association health plans. So this was the old rule, and under the old rule, things were pretty strict. You had to, let's go over here, I'll back up again. You had to have a commonality of interest standard, and it was a heavy one. It was not an easy burden to meet. They narrowly interpreted ways in which you could pair together. So I'll let you see that language later. The new rule said, wait a minute, you don't just have to have this commonality of interest. You could be paired together by geography alone. So if you wanted to form an association health plan under old guidelines, you had to have another reason for the entity to exist. It couldn't just be this provision of benefits. And you had to meet strict criteria to keep it going. And the Trump administration said, well, we want to make this a lot easier, so we're going to just go straight geography, or we're going to give you this broad business and professional interest, which they said was really vague. And when the court system got a hold of this, as you'll see, they tore it apart. The old AHP bona fide group, there's your strict standards that I was referencing. Commonality of interest standard, it's there in case you want a quick snapshot of it. And then we'll go kind of jump ahead here to the litigation. So you had, this was within the past 2 or 3 weeks, the verdict came out here. So this was state of New York for the U.S. Department of Labor. You had 11 state attorney generals in D.C. filed suit. They said, really, you're punching a hole in the entire ACA with this. This is an end around. And ultimately, those states won their case. And here's sort of the summary of it. Court objected to the new concept that a sole owner was both an employer and an employee. They talked about scenarios where you could have 50 different people who were sole owners come together and be labeled both employers and employees and be outside of pretty much all the mandates of the ACA simultaneously, and they said this doesn't make any sense. And this was a Bush-appointed judge, so this isn't one of the partisan things where you think it might get repealed when it's appealed. Okay, so no federal preemption. Insurance is still regulated by the states. I mentioned that earlier. Okay. Different types of AHPs. So this is where it gets confusing, and if you took a picture of that intro slide where you're looking at different entities, you got AHPs, and then the next one was MEWAs, which is a multiple employer welfare arrangement. Depending on how that's designed, it could be an AHP. MEWAs are regulated at both the federal level and the state level. This was in spite of efforts to block that back in the 1980s. So if someone's pitching a MEWA to you, you've got to ask them, one, is it also an AHP? And two, which state do you want it to be in? And how creative are you going to get? There are 6 different states that actually have some language on the books that says we will accept out-of-state insurance plans. But the other 44, that does not apply. So if you wanted to have a MEWA that you were trying to market nationally, you've got to deal with federal law, which is ever-changing and recently overturned at the judiciary, and you've also got to deal with probably 50 different state laws. So it's not as clean as people want it to be right now. Okay. I already said that. And there's some of the controversies that have happened there. MEWAs and especially the STLDI plans, which we'll talk about a little bit later, were historically ripe with abuse. You would have, the door-to-door salesman kind of thing, and then all of a sudden the company's bankrupt a year or 2 later, and they've taken all these premiums and left the country. So you've got to be careful with that. Is a MEWA a type of AHP? Maybe, maybe not. Usually not. Is it a type of ERISA plan? Yes, but it's not required. And can it be paired with an HRA? The answer is yes. And it can even be paid for through an HRA, which is something you can't do with a short-term limited duration insurance policy. So this is where it gets really messy, and I apologize I'm moving so quickly. Okay. That part I've covered. Are you confused yet? Okay. So I've got a 2-page handout on this that hopefully will make it cleaner. But here's your summary slide. So ERISA plans are viewed as an alternative to ACA. They let you come across the entire country if you're an employer and offer it everywhere, if you're Walmart and you want to have this everywhere. How can you do that? You can do it through several vehicles. You can try and do it through an AHP or a MEWA, and you may or may not pair an HRA with it. So the big takeaway for you so far is judges have ripped up the AHP MEWA stuff so far. It's really not new, not unless there's something surprising on appeal. And what can you do with HRAs? That's going to be where we're going. This is another summary slide if you're wanting to compare things and note the fiduciary duty piece at the bottom only applies under ERISA. So HRAs. These are group health plans that are funded solely by employer contributions, and they reimburse solely for 213D medical expenses. So for those paying attention, why can you not use an HRA for DPC right now? Because the IRS thinks DPC isn't a 213D medical expense. So that's where, while we try to fix the HSA issue at the federal level, we're also fixing the HRA issue, which could be just as important. Employers like HRAs because they can contribute all kinds of different amounts to them. They can fund them as needed. They might not even pay anything into the HRA until the employee is about to take the money out. So they don't have to deal with the rollover issues that you hear about with FSAs and the complications for HSAs, which I got ahead of myself. You'll see some of that summary there. All patients with an individual HRA still have to have individual coverage, and an STLDI doesn't count, although the tax is now $0. So what about employers that have less than 50 employees? That's been discussed several times today. This isn't changed a lot by Trump's executive order. You have what's called a QSARA, so a Qualified Small Employer, HRA. Those were added by the Cures Act, which was about 2 to 3 years old at this point. It used to be if you were a small employer and you offered an HRA without offering a full kit and caboodle 10 essential health benefits plan, you were charged a massive $100 per day fine per employee, which was a huge risk no employer wanted to deal with. This was changed by the Cures Act. So if you're dealing with a less than 50 employer, they could fund only an HRA, a QSARA HRA, and not get in trouble tax-wise. Okay, so that's sort of your broad exception is your less than 50 employers right now can operate things solely with an HRA. Those can even be paired with Medicare, TRICARE, and retiree-only plans, apparently. So why expand HRAs? Because historically an ACA group health plan and no monetary limits applied to benefits, and HRAs may not be used to fund premiums for employees with individual health plans. So that was the old problem. They're trying to make the standard HRA more like the Qualified Small Employer HRA. Okay, there are 2 new types of them that were proposed. This rule has not even been finalized yet, so the process here is that you propose a rule, you finalize a rule, and then you wait on the judiciary to decide if it's constitutional or not. So this stage is very early. It's not even been finalized, but this is their proposed expansion. Okay. If it were finalized, they've designed it to take effect January 1st. I suspect that would be delayed. If this does pass as is, does it matter much for the DPC community? Well, certainly it does, and it matters a whole lot more if we get our 213D and 223C corrections. Okay. And there's the STLDI overview. I've run out of time. I tried to go as quick as I could, but the key takeaway here is that these plans were traditionally only available for 3 months, and now they're available for much longer time periods, but the regulations still haven't changed. So they don't get you out of the ACA fine, which is currently $0, so it doesn't matter. But there is a lot of buyer beware issues with these policies. So, thank you.